Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in this today's very important video session, we are going to discuss again the very important multiple choice questions and its concept. So, in clear, in perfect. So, my thing is very clear in this particular class to give the high yield content in a very perfect manner with perfect explanation and in a manner that becomes useful to you people when you will sit in front of the computers in the exams. Okay, so whatever the points I am discussing, is every point is golden point, because the entire pharmacology I am summarizing and I am trying to do my best in the only two classes. Okay, so today's class, tomorrow's class, the pharmacology entire important concept and questions will be finished. Okay, so this is a more than sufficient from my perspective for your upcoming Norcet prelims and the mains exams. Okay, so the prelims and mains exams, where in the prelims the question of the like pharmacology, which ranges from the 3 to 5 questions may arise in the prelims, and in your mains exams there is chance of the asking 6 to 8 questions from the pharmacology. Okay, so that is only repeated questions, the important questions and the questions which is necessary for examiner. So that questions will be only struck in your exam. So I am giving my best shot in this particular class, okay, to cover your syllabus on the pharmacology. So please do watch the class till the end, and the class may go lengthy. Don't leave the class in middle, because this is the class to give the best marks in your upcoming exam. Okay, yes. So I want everybody's perfect involvement in the class. Okay, so yes. So without wasting the time, we will start the class with powerful motivational line. A very good evening to one and all who are watching the class. Yes, फटाफट hit the like button, and if anyone of you are new to the master nursing classes, so please subscribe to the channel. Yes, so hit on the subscribe button, the red button which is visible to you all, so that is the subscribe button. So please click on the subscribe button, and if you like the content and the previous classes, if you like, so please do like to this particular video, right? Yes, so without wasting the time, we will start the today's session with this powerful motivational line. Students, mastering others is the strength, mastering yourself is the true power. So I used to tell repeatedly, if you want to improve in your life, invest on your particular life. Okay, so whatever the money you want to invest on you, whatever the time you want to invest on you, whatever the belief trust you want to build, so it have to be a build on you. So if you are a believer, if you are a strengthful person, so no one can, no any bad energy can stop you to get success, right? So don't try to master over others, so try to master over yourself, so everything will becomes under your control, right? So that is the a very important line shared by the many and followed by the many champions. Okay, so try to improve yourself, so everything will comes to you, right? So with this powerful motivational line, we will start the today's session. A very good evening to one and all. So please don't join to the class in late. Okay, so try to be on time, so that will be helpful, right? So yes, here's the first question which is in front of you all. So please try to read the question carefully, completely, and try to give the best answer. Which of the following is the primary site of action of the loop diuretics in the nephron? Okay, so in the nephron, where the loop diuretics acts on? Option A, proximal convoluted tubules. Option B, distal convoluted tubule. Option C, thick ascending limb of the loop of the Henle. And option D, collecting duct. Yes, where actually the very important loop diuretic will act on the nephron. Students, nephron is a very basic unit of the kidney. Okay, so which is responsible for the various functions like filtration of the blood, secretions of the waste materials from the blood. Okay, and it will produce the urine and it will excrete the urine. The structural and the functional unit of the kidney is the nephron. Okay, the structural and functional unit of the body is cell. Yes, the next question, the structural and functional unit of the lungs is, yes, the structural and functional unit of the respiratory system or the lungs is alveoli. Okay, so do remember the very important one liners. Okay, so where on the nephrons we have the different parts. Okay, so like this is the part of the nephron. Consider, okay, this is the Bowman's capsule. This is the Bowman's capsule. Okay, this one is the proximal convoluted tubule. This one is the descending loop of Henle, which is coming down. So we call this one is the descending loop of Henle, right? So this is going up. So we call this one is in the ascending loop of Henle. Okay, so this one is the parts of the loop of Henle. Okay, so this one is the ascending loop of Henle, and this is away from the particular Bowman's capsule, so we can say this is distal. Okay, this is the distal convoluted tubule, and this is near, that is what we call the proximal convoluted tubules, right? So this one is the collecting duct. So where the loop diuretics will act, diuretics will act on the thick ascending loop of the Henle. Okay, so this is our correct answer goes to this particular a very important question. Better. So on the nephron where the loop diuretics will act, so on the nephron it will act on the very important thick ascending loop of Henle is your answer. Okay, so hope it is clear to everyone. Okay, so option C goes to the answer, and many of you have chosen the correct answer. Okay, so here the different diuretics we have. The diuretics are the drugs which increases the urine output. Okay, so we will use in the various conditions. I will explain that one. Okay, and where we will use the furosemide as a drug of choice. Okay, where we should not use the mannitol. Okay, in what are the situations, how the scenario based questions will be created in front of you all from the diuretics. Everything in perfect I will explain to you people, okay, in a short duration, so it will be useful for your exam. Okay, so look at this one. So various types of the diuretics we have here. First one we are having is the carbonic anhydrase inhibitors. Okay, so this carbonic anhydrase inhibitors. So in this one we will study the acetazolamide drug. Okay, so that is a very important drug, the drug of choice for the mountain sickness. The drug of choice for the acute mountain sickness is the, yes, that is our acetazolamide. So that one comes under the classification of the carbonic anhydrase inhibitors. So this carbonic anhydrase inhibitors site of action is the proximal convoluted tubules. Okay, so where the carbonic anhydrase inhibitors work, it will act on the proximal convoluted tubules. Okay, so next to the loop diuretics, it will act on the loop of Henle. So which loop of Henle, sir? Descending loop of Henle, or the ascending loop of Henle, or the a thin loop of Henle, or the thick loop of Henle? Better. So are you able to see the structure here? This is the thick. Okay, this is the thin, right? So, and this is coming down descending loop of Henle, and which is going up ascending loop of Henle. So I told where the loop diuretics is acting, loop diuretics are acting on the thick and ascending loop of Henle. Okay, so here this is the site of action of the loop diuretics. Okay, so next the thiazides. Okay, in the thiazides we will study the short acting, that is the chlorothiazide, and the long acting drug, that is the hydrochlorothiazide. Okay, so the thiazide will work on the distal convoluted tubules. That is the very important. Okay, so next potassium sparing diuretics. So in this particular potassium sparing diuretics we will study the very important spironolactone. Okay, so the spironolactone which acts on the collecting duct. Okay, so these are the site of action of the diuretics. So quickly I have revised in front of you people, so take a screenshot, okay, and revise immediately after the class. It will be helpful for you all. Okay, so hope it is clear to every one of you. And the first question answer goes to the thick ascending loop of Henle. Okay, so that is the very important. Okay, here is the next important question which is coming in front of you, and it is waiting for your brilliant answer in the comment box. So please try to read the question completely carefully and try to give the best answer in the comment box. So this is the very frequently asked question, and this one is the very important question. Okay, so this is the very important question and a very frequently asked question. Okay, so in a patient taking the furosemide is the drug which comes under the loop diuretics. Okay, so this one we also call as the injection Lasix. Okay, so we call this one as in the injection Lasix, or we call this one as in the injection furosemide. Yes, so this furosemide or the Lasix patient is taking. Which of the following electrolyte should be mostly and most closely we need to monitor here? Better. So do remember, whenever the patient who is taking the diuretics, there is highest chance of the elimination of the sodium is there, potassium is there, and the calcium is there, and the magnesium. So this all the electrolytes will get lost. But if magnesium is getting lost, okay, for the sometimes we can manage. For the calcium is getting lost, so okay, there is no that is not in a big and serious khatarnak conditions. But potassium we need to replace immediately, because this is the matter with heart. Okay, because heart requires the potassium for its normal rhythm, its normal regulations. If the potassium is increasing, decreasing, means the patient will land into the dysarrhythmia and death. So the very important electrolytes we must and should monitor during the patient who is taking the diuretics is the that is our very important potassium, right? even if you will get the option of the sodium, magnesium, calcium, so please give first a priority and best answer to the potassium. Yes sir, sodium is decreasing or not? Yes, of course the sodium is decreasing. Potassium is decreasing is not, sir? Yes, of course the hypokalemia is happening, hyponatremia is happening, hypocalcemia is happening, hypomagnesemia is happening. But the dangerous situation and the most closely we need to monitor for the potassium, this is a very very important thing, just you have to keep in your mind. Okay, so hope the answer is very much clear to the drug on the furosemide or the Lasix. Okay, so do remember this golden words on the Lasix. Beta, Lasix is the drug of choice. Is the drug of choice for the acute pulmonary edema, APE, acute pulmonary edema में drug of choice कौन सा है? That is our injection Lasix. So what is the dosing, sir? That is the injection Lasix 40 mg IV BD. Okay, so this is the usually and most commonly used dosing of the injection Lasix. So please do remember the very very important. Okay, so that's the, it based on the blood pressure of the patient, it based on the renal function of the patient, it based on the polyuria and urea conditions. So it will work, the dosing will be changed, but this one is the most commonly used dosing form in the clinical settings. Okay, please do remember the most common and the drug of choice for the acute pulmonary edema is our injection Lasix or injection furosemide. The very very important point. And the next, in the congestive cardiac failure also we will use the Lasix, because it is increasing the urine output and it is putting the all the plasma concentrated and the wasted plasma out. And one important thing, it is reducing the circulatory overload. Okay, so in the overload, in the congestive heart failure, the blood vessels and heart is congested with fluid, it is overloaded with fluid. So when I will give the diuretic, the fluid will go out of the body, and in the congestive heart failure we will use the very important Lasix as a very important and first choice of the diuretics, or the furosemide as a first choice of the diuretics. Okay, next come to the case of the edema due to the liver cirrhosis and nephrotic syndromes. Okay, so there may be a case of the anasarca. Okay, what is anasarca? Anasarca is the entire body edema. Okay, so what is the anasarca? Anasarca is the entire body edema, we call that as anasarca. In case of the anasarca also we will use the injection Lasix, because it is putting the fluid out of the body. Okay, so by increasing the urine output, right? So whether can we give the this particular Lasix injection in case of the polyuria? Beta, already patient is having the polyuria, highest risk of the dehydration, don't give. Sir, whether can we give this Lasix in the case of the hypotension? Beta, already patient plasma concentration is low, so don't give in the hypotension. Yes, you can use the diuretics in case of the hypertension. Yes, you can use the diuretic in case of the hypertension, and you can use the diuretic in case of the what we can say, oliguria. But never ever use the furosemide in case of the anuria. So complete absent of the urine, or the urine output if less than 100 ml. So this time the entire function of the kidney is completely reduced. So we call this one as the anuria. But if the urine output is less than 400 ml, so we call this one as in the oliguria. So in case of the oliguria we can use. Okay, in case of the oliguria we can use the Lasix. But in case of the anuria, we will not use the Lasix, because it will be won't helpful, right? So I hope all the important golden point we have revised here, and important monitoring we have to do during the diuretics is the, we need to monitor for the electrolytes, especially for the potassium. Then the magnesium, sodium, calcium also we need to monitor, because there is chance of the hypokalemia, hyponatremia, hypomagnesium, hypocalcemia will happen. So, okay, so renal function also we need to monitor here. Okay, so especially blood urea nitrogen and the creatinine and urine output we need to monitor. Why? Because yes, if it is anuria, so there is no use of the diuretic. So if you want to diagnose this one as an anuria, so we need to monitor the urine output. Okay, and so the question will comes. Okay, question will comes. So this is the patient who is admitted with the congestive heart failure. Okay, and who is on the injection furosemide. Okay, so now the nursing officer noticed increased volume of urine in urine bag. What it indicates? Beta, what it indicates? What it indicates? Option A, it indicates the furosemide toxicity. It indicates the normal effect of the furosemide. It indicates the no use of the furosemide. It indicates the need for one more drug. Beta, in a case of the congestive heart failure, we are giving the diuretic, so it is increasing the volume of the urine, so it is normal one. Okay, it is normal one. Okay, so it is indicating the therapeutic action of the pyrosamide. So I hope it is clear to everyone of you. This kind of the simple questions they will make in a complicated situations. Okay, just you people have to be stick on the very basics. Think very simply. Don't think multiple with unnecessary things. Okay, so I know you people have gone through it various books. I know you people have are referring the various Telegram groups, WhatsApp groups, where the one group will give the one different answer. So that is today, because you are confused because of these unnecessary things. I keeps on telling you people, join the one thing and believe in one thing, repeat the one thing, so that will help you, all right? So don't worry, I am here to give the quality, I am here to give the clarity. Okay, so that is my promise, right? So hope it is clear to every one of you. And the most importantly, we need to assess for the daily weight. Okay, if the urine output is getting excessively lost, so the weight of the body will be reduced. Okay, so we need to monitor the daily weight and we need to monitor the daily intake and output. So that is the very important thing. Two things we need to monitor in the patient who is taking the what we can say diuretics therapy. Okay, and the blood pressure we need to monitor. If the blood pressure is less than 90/60, we need to inform to the doctor before giving the diuretics, because the already patient is in a situation of the hypertension, and in case of the hypertension we will not give the diuretics. Okay, I hope all the golden points on the this particular diuretics is revised here. And one more important and your practical questions which will come in your exams, I told better the dosing of the diuretics will be like this. Okay, so that is the injection Lasix 40 mg IV BD. So here BD means we need to give 2 times in a day. Okay, so 2 times in a day. So when you will give option A morning 8 am and 8 pm, option B morning 8 am and the 4 pm, option C morning 8 am and the night 10 pm. So option D any of the above. Okay, or the all of above. So when you will give the a dose of the Lasix, better you need to give the dose of the Lasix before 5 p.m. Okay, if you are giving in the late evening or if you are giving in the late night, the patient won't sleep, because the diuretic is the drug which increasing the urine output. So entire night he will go for the washroom. Frequently patient will wake up. It will cause us the sleep disturbance. So sleep disturbance means the patient next day recovery is hampers. So that is the reason almost all the doctors avoid the prescription at the night time. And as a nursing officer, you must and should know, if the BD dose of the Lasix is going on, so you have to give the 2 times a day, means just give first dose in the morning 6 to 8 am anytime, and the next dose in the 4 p.m. or the maximum you can give till the 5 p.m. Okay, so after the late night, so don't give, because it increases the very important urine output at the night time. So night time patient won't able to sleep. Okay, so avoid the night dosing of the diuretics and prevention of the nocturia and prevention of the sleep disturbance. Okay, so this is the very important golden point for your exam. Okay, hope it is clear to every one of you. And here comes to the next question, which is awaiting for your brilliant answer in the comment box. Okay, so whatever, do read the question and mention the correct answer in the comment box. यस बेटा, स्लो भी बोलूंगा लेकिन अभी नहीं, अभी फास्ट चलेगा क्लास, क्योंकि जो मेरा जेन्युइन स्टूडेंट्स है उनके लिए सिलेबस कवर हो जाओ तो उनका रैंक मस्त से मस्त आ जाए. So that is the my wish. Okay, so the main thing is to cover the important questions and cover the important concept and build it and revise it to in front of you, so you can easily choose the correct answer without any confusion in the our Norcet 8 Norcet 9 prelims and Norcet 10 Norcet 11 anywhere you are giving after watching my class. Okay, so if you are feeling you are gaining the knowledge, yes, you will definitely get the good marks in the exams. Okay, so yes, almost all you people given the correct answer. Which of the following is the common side effect of the thiazide diuretics? Okay, so which of the following is the common side effect of the thiazide diuretics? Better, thiazide diuretics are the diuretics. In this one we will study the main important drugs. So that is the chlorothiazide and hydrochlorothiazide. Okay, so chlorothiazide is the chlorothiazide is the short acting and the hydrochlorothiazide is the this is the long acting. Okay, so these thiazide drugs which will increases again the urine output. Okay, urine output will be increased, but it not eliminates calcium. Okay, it not eliminate the calcium, or it will increases reabsorption of calcium. Okay, it increases the reabsorption of calcium. So please do remember the very important golden points on the thiazide diuretics. Okay, so thiazides are the diuretics where it is using to improve the urine output, but it reducing the calcium excretions in the urine. Okay, it is not excreting the calcium in the urine, and the entire calcium is reabsorbing, and this leads to the increased serum calcium level. A very important point, please do keep in your mind. Okay, so along with this, if the calcium is not going out of the body, the calcium is increasing in the serum means, so we can use this diuretics in case of the osteoporosis. What is the osteoporosis? Osteoporosis is a bone disease conditions where the bone strength, bone potentiality will get weak because the density of the bone will get decreases. So what is the density of the bone? What is there the main component inside the bone? Yes, inside the bone the main component is the calcium. So calcium is decreasing means the bone density will decreases, the bone strength will get decreases, and bone will become more fragile to get fracture. Okay, so that is the reason. Okay, so here in the thiazide diuretics, which is not eliminating the calcium, which improves the calcium level in the body. Okay, so that is the reason in the osteoporosis calcium is decreasing, but the thiazide diuretics which calcium is increasing, so we can give the thiazide as a best diuretics in the case of the osteoporosis. Okay, and thiazide may help to reduce the bone loss and decreasing the urinary calcium loss also, it will get decreases. So but it increases the risk of calcium stone. Okay, which increases the risk of calcium kidney stone. Okay, so please do remember the very important one. Okay, so hope it is clear to every one of you, and almost all you people given the correct answer for the question. Okay, so which will causes the hypercalcemia. Okay, so which will causes the hypercalcemia as a correct answer. So option B goes to the correct answer here. Okay, yes. Here comes to the next question. Which of the following is the drug of choice for the mountain sickness? So already we have discussed with this one in the first question only. I have told. Okay, in the explanation of the first question, I have told which of the following is the drug of choice for the mountain sickness. Yes, which of the following is the drug of choice for the mountain sickness? Option E, amiodarone. Option B, astazolamide. Option C, spironolactone. Option D, Lasix. So what goes to the correct answer here? Yes, very good. Very good. Yes, all you people already know the pharmacology. Just one time need to brush up, one time need to revise. That is more than enough. Okay, so which of the following is the drug of choice for the mountain sickness? And almost all you people given the correct answer, so that goes to the answer goes to the astazolamide. So astazolamide is the carbonic anhydrase inhibitor, so this will be a diuretics. Okay, so this one we can use in the treatment of the mountain sickness. Okay, so why? Because it will having the ability and capacity to reduce the production of the CSF, which maintains the balance in the brain. Okay, so that is the very important, and it will not allow the ICP, intracranial pressure, to rise and fall during the mountain periods. Okay, so that's the very important. Just you have to keep in your mind the drug of choice for the mountain sickness is the astazolamide. Okay, so this astazolamide, so we will also use in the treatment of the glaucoma. So what is glaucoma, sir? Glaucoma is a condition of the eye. So it is the condition of the eye where there will be an increased intracranial pressure will be there. Okay, sorry, increased intraocular pressure will be there. Okay, so this increased intraocular pressure which creates the pressure on the like optic nerve, and it may lands the patient into the blindness. Okay, if we are not treating properly. So that is the glaucoma is the increased intraocular pressure which is having the ability and potential to damage the optic nerve. Okay, so that is the may lead the patient may lead into the blindness. Okay, so in order to avoid that one, we need to manage this intraocular pressure normally. Okay, so remember this particular concept what I am explaining, so please do remember, because it will be helpful for your. Yes, so what is the glaucoma, and I will tell why we use the astazolamide in the glaucoma. So please do remember, very important. Glaucoma is the very important condition for you, right? So this is the What is this? This is the cornea. This is the outermost layer of the eye. So that is the sclera. And here will be our iris. Right? This one will be our iris. And here will be our eval body. And here will be a middle layer of the eye. So that is our choroid. And here comes to the inner layer of the eye. So that is our retina. Right? So this is the structure of the eye. Okay, so here which comes to the suspensor muscles which holds the lens in the place. Okay, so suspensor ligaments which holds the lens in a place. Okay, so this is the posterior part of the eye, posterior compartment. So this comes to the anterior compartment. Okay, so here in the anterior compartment we again divide this one into a anterior chamber and the posterior chamber. Okay, so the part which is above the in front of the iris, so that is the anterior chamber, and this is the part which is behind the iris, we call that one as the posterior chamber. Okay, so posterior chamber is in between the iris and the lens. Okay, so anterior chamber is in between the cornea and the iris. Okay, so in the between the cornea and iris we have the one small hole, so we call this one as the trabecular meshwork. Okay, so from this particular EVL body, so the fluid, the very important fluid, it will produces from the EVL body. So that is our aqueous humor. Okay, so that is the aqueous humor. Okay, and it will comes to the anterior chamber. Okay, from the posterior chamber it will comes to the anterior chamber, and in the anterior chamber it will get absorbed. So this is the normally how our physiology works. Okay, so aqueous humor will be produced in which chamber? Aqueous humor will be produced in the posterior chamber. Aqueous humor will be absorbed in which chamber? Aqueous humor will be absorbed in the anterior chamber. Okay, so vitreous humor will be present in which part? So vitreous humor will be present in a posterior part of the eye. Okay, so please do remember the very important thing for your exam. Okay, if in case this particular aqueous humor is overproducing, okay, it is overproducing, that time the pressure inside the anterior part of the eye will increases, right? Or else this particular small opening I told, the trabecular meshwork. Okay, what is this one? This is the trabecular meshwork. So if the trabecular meshwork is get blocked, okay, so if it is overproducing, also IOP, the intraocular pressure will increases. If this particular trabecular meshwork is blocked, means yes, again the fluid will not drain. So again the aqueous humor will be increased in the anterior chamber. Again the intraocular pressure will increases. Okay, so here what we have to do? Here we have to reduce the production of the our aqueous humor. So in order to reduce the production of the aqueous humor, we will give the carbonic anhydrase inhibitors. So that is the acetazolamide. Okay, so that is the acetazolamide is the drug. So we are using a very importantly here to reduce the production of the our aqueous humor. Okay, so and here in order to open this particular small opening, so we will do one surgery. So that is what we call the trabeculoplasty. Okay, trabeculoplasty. Plasty means repair. Okay, so trabecular means trabecular meshwork. Here we are repairing. Okay, and we are reopening that one. So that is what we call the trabeculoplasty. As a surgery we will do here, and the acetazolamide as a drug we will use here. Okay, so this is the very important concept you have to keep in your mind. Okay, so what are the thing we have discussed here? Yes, aqueous humor will be produced by the our vitreous body, and aqueous humor will be produced in the posterior chamber, and aqueous humor will be drained in the anterior chamber in the trabecular meshwork. Okay, and the IOP will rises in the glaucoma. Okay, what is the normal IOP? Normal intraocular pressure. So that is the 10 to 21 mm of Hg is the normal intraocular pressure. So very important, right? So the intraocular pressure which is increasing means which causes the glaucoma. Okay, in the glaucoma that happening due to the overproduction. So in order to reduce the production, give the acetazolamide carbonic anhydrase inhibitors, and which happening due to the blockage of the mesh here. So in order to open the mesh, we will doing the surgery called as the trabeculoplasty. Okay, so these are the very important golden points we have discussed here. Okay, so let's come to the point of the discussion here. I told this one I am using in the treatment of the glaucoma also, that is the acetazolamide. Okay, and acetazolamide I will use in the treatment of the, okay, so what we can say, increased intracranial pressure also. Okay, because it will reduce the CSF production also. Okay, so remember It acetozolamide will decreases CSF production also. Give me 1 second, please. Yes, it decreases cerebrospinal fluid production also. Okay. So I can use this one in the case of the increased intracranial pressure, especially in case of the hydrocephalus. Okay. In case of the hydrocephalus in children's, so we can use this one. Okay. So very, very important. So please do remember the golden points. Acetozolamide used in the glaucoma, acetozolamide used in the hydrocephalus, acetozolamide used in the as a drug of choice of the mountain sickness. Okay. So hope it is clear to every one of you. Yes. So next comes to the question. So that is the very, very important here in front of you. Yes. Which of the following is the common clinical use of the mannitol? Mannitol. So students, mannitol is a osmotic diuretic, which comes under the classification of the osmotic diuretics. Okay, so in osmotic diuretics, previously we have the lots of the diuretics like a glycerol and all. So now we are not using the glycerol and all. Also, we are using the mannitol, especially mannitol 20%. So that's the recommended one we are using now. Okay, so in the clinical settings. Okay, which of the following is the common clinical use of the mannitol? Option A, treatment of the hypertension, beta. So what is the what I told regarding the mannitol? Mannitol is the osmotic diuretic. Okay, so this is the blood vessel. Okay, so this is the blood vessel, and inside the blood vessel, okay, so there will be a blood will be there. Okay, so inside the blood vessel there will be a blood will be there. Whenever I will infuse the mannitol here through the IV canal, okay, mannitol will comes here, and it which increases the osmolarity. Okay, so it increases the concentration because it is the a hyperosmolar. Okay, it is the a concentrated fluid, that is the mannitol. Whenever the mannitol will comes into the blood pressure inside the blood vessel, okay, it will pulls the blood, okay, from the extravascular compartment to the intravascular compartment. All the blood will move inside the blood vessel. Okay, especially the blood fluid which is accumulated in the brain cells. Okay, so fluid which is accumulated in the uh, other cells. Okay, so which will comes from the intracellular space or from the extravascular space to the intravascular space, it will comes. Okay, so now the volume inside the blood vessel is what happening, the volume inside the blood vessel is increasing. So if already patient is hypertensive and you are giving the osmotic diuretics, again the volume is increasing in the blood vessel, means again it will cause the hypertension. So it will, the patient may land into the severe hypertension. So don't give the mannitol in a patient with the hypertension. Okay, so very important. So we are not using in a clinical use for the treatment of the hypertension. Okay, so next comes to the option B. So that is the reduction of the intracranial pressure. Yes, I told this is the intracranial cells. Okay, so from here the fluid is moving inside the cells, so we can reduce the pressure from the, okay, so from the brain. Okay, so that is the very, very important use of the mannitol, and almost all you people have given the correct answer. And the management of the chronic heart failure, better. So this mannitol is again contraindicated in the case of the chronic heart failure. Why, sir? So in the heart failure, what happening, sir? So heart failure, the blood is congesting. Okay, already blood congestion is there, okay, on the blood vessels, because this is the heart and which is failing to pump. Okay, which is failing to pump means, so all the veins, okay, and all the arteries, right, so everything are congested and already which are overloaded with the fluid. Okay, but if again you are giving the mannitol, and mannitol, what it will do, it will again increases the concentration in the blood, and again it will pull the blood like extravascular fluid back into the intravascular space. Okay, so again the fluid overload will be there and the congestion will increases, congestion of the blood vessel will increases. So mannitol I will never ever give in a case of the heart failure. So that is a very, very important point of the discussion you have to remember. Okay, so management of the chronic heart failure, so mannitol I can't use. Okay, so next come to the treatment of the hyperkalemia. So it is not useful, right? So I hope the answer is very much clear. The answer for this question goes to the option B, reduction of the intracranial pressure is the a common clinical use of the mannitol. Okay, so that is the very, very important. So please do remember your question. Okay, so here is the next question comes to you all in front of you all. So like this. Yes, please do read the question carefully, completely, and try to give the best answer in the comment box. Yes. Which electrolyte imbalance is most commonly associated with the spironolactone use? Better, we are using the thiazide diuretics, we are using the loop diuretics, especially mannitol also. Here, all these diuretics decreasing the potassium level. But one diuretic where it is increasing the potassium level, so that is our spironolactone, or we can say the classification of the potassium sparing diuretics. So what it means, beta, the wherever the word sparing comes means that means it is accepted, right? Brain sparing effect on the body means brain will be normal. Okay, so brain growth will be increased and entire body growth will be damaged. So that is what we call the brain sparing effect. It means brain is okay, entire thing is decreasing. Again, here the potassium sparing effect means potassium will be same or it will be increased and everything will be decreased. So similarly in the potassium sparing diuretics, so we are using the spironolactone. So this drug which will increases serum potassium level. Okay, so most commonly associated electrolyte imbalance along with the spironolactone is the our hyperkalemia goes to the correct answer. Then in a patient who is taking the spironolactone, you have to educate not to take the potassium rich food. Okay, not to take potassium rich food. Why? Because this potassium rich food again which increases the patient serum potassium level, and increased serum potassium level again lands the patient into hyperkalemia. Okay, so this is the reason. Okay, so not to take the potassium rich food is the primary education we need to give. So what are the potassium rich food we need to educate, sir? Not to take. Yes, so don't have the banana. Banana need to avoid. Coconut water need to avoid. Okay, so because this banana, coconut water, and many yes, what are the potassium rich food? Yes, beta. Yes, these are the very basic and many things are there which is rich in the potassium, but we need to educate the patient to avoid all the potassium rich food. Okay, so this is the very important. We need to educate the patient who is taking the spironolactone. Okay, so who is taking the furosemide, we will advise the patient for having the potassium rich food. Okay, because in the furosemide, that is in the Lasix, there is the chance of the what happening in the Lasix. In the Lasix, there is hypokalemia is happening, so we are giving the potassium supplementation. But on the spironolactone, on the potassium sparing diuretics, there is a hyperkalemia is happening, so we are educating the patient to take the not to take the potassium rich food. Okay, so that is the very important questions, so you have to remember in your mind. So that is important, right? Next question comes to you all here. Yes, when educating the patient on the diuretic therapy, what is the important nursing point need to include? Option A, avoid the potassium rich food to prevent the hyperkalemia. Beta, we are the question is asking on the overall diuretic therapy. Okay, so in the overall diuretic therapy, the most commonly used one is the Lasix or the furosemide. In the furosemide, the potassium is getting lost, so hypokalemia is happening, and we are advising the patient to avoid the potassium rich food. Already potassium is decreasing, and we are advising to avoid the potassium rich food. So again, the patient will land into the severe hypokalemia. Okay, so that is the reason I will not ask the patient to avoid the potassium rich food. Okay, so I will ask the patient to take the potassium rich food who is taking the diuretic therapy, except on the potassium sparing diuretic on the spironolactone. I will not ask to have the potassium rich food. Okay, other than that, all the diuretics we need to educate the patient to ask to have the potassium rich food. Okay, so that is the very important. Do keep in your mind. Okay, the next option B comes to take the medication late at the night to avoid the daytime urination. Better, I have created the scenario and I have told to you people already that morning 8 a.m. and the 4 evening 4 p.m. dose we have to give, and we should not, and we should and must, and we should never ever should give the diuretics at the night time. So the concept I have explained, because it will increase the nighttime urination and the nocturia. Okay, so that, and it will cause the sleep disturbance also. Okay, so that is the reason take the medication at the late nights to avoid the daytime urination is the inappropriate word. Okay, so that is not a a very important nursing point we need to include here. Okay, so that is not an important nursing point because it is the wrong statement. Okay, so the next is the report the muscle weakness and cramps immediately. Better. So patient is taking the diuretic therapy. There is a highest chance of the, okay, so potassium loss is there, and the earliest sign of the low potassium is the, so that is the muscle weakness and the muscle cramps. Okay, so that are very very important. So please do remember, if the patient is expressing the early sign of the hypokalemia, so we need to withhold the diuretic therapy. So that is the very very important thing. So this one we need to most and should educate the patient who is having the diuretic therapy. Okay, so hope it is clear to every one of you, right? So the next question is here comes to in front of you like this. Yes, which nursing consideration is important when administering the aspirin? These are the very repeatedly asked drugs on the aspirin: adrenaline, okay, atropine, diuretics, digoxin, lithium, okay, and antipsychotics, and along with that, along with antipsychotics, antidepressants. So these are the questions which will definitely strike in the exam. So we are going to fix those questions here, okay, because these are the important for your exams. Okay, so which nursing consideration is important when administering the aspirin? So please do mention your answer in the comment box. I'm waiting for your response in the comment box. So please फटाफट mention your answer. Yes. Which nursing consideration is important when administering the aspirin? Option A, monitor for the sign of the bleeding and bruising. Option B, restrict the fluid intake. Option C, administer with the antacids only. And option D, avoid monitoring the liver enzyme. So which nursing consideration is important when administering the aspirin? Beta, this aspirin is a drug. It will comes under a classification of the non-steroidal anti-inflammatory drugs. Okay, so which comes under the classification of the non-steroidal anti-inflammatory drugs, and it is a very important COX-1 inhibitor. Okay, sir, what is this COX-1 inhibitor? So what actually this particular concept we are not getting? Okay, let me quickly explain the concept behind this one, and so we will come to know all the physiology. Okay, so what is the COX inhibitor? So I will explain the physiology, so you will be getting understand it very easily. Okay, so listen here. Whenever our normal body cell, it will get damages. Okay, so the cell wall will get damages. Okay, cell wall will get damages. So this particular cell wall, which is having the biphospholipid, okay, which is having the biphospholipid. Okay, so the cell wall is damaged means biphospholipid also will be get damaged. So this biphospholipid, it will get converts into the arachidonic acid. It will get converts into the arachidonic acid. Okay, so this arachidonic acid, it will stimulate the COX pathway and the LOX pathway. Okay, so here is the cyclooxygenase pathway, and here is the leucooxygenase pathway. Okay, so whenever there is in the stimulation of the COX, so that time this particular COX stimulation, what it will do, it will increases the prostaglandin, it will increases the prostacyclin, it will increases the thromboxane A2. Okay, so prostaglandin increased means the cell is damaged, cell wall damaged means prostaglandin increased. So prostaglandin increased means the patient will be having the pain. Okay, and the prostacyclin and the thromboxane A2 will increase means, okay, so cell wall is damaged means the bleeding is coming. In order to control the bleeding, yes, the thromboxane A2 is also, it will get activated, so it will stop the bleeding. Okay, it will stops bleeding. Okay, and similarly LOX will be stimulated. So LOX is that is the leucooxygenase, which will increase the leukotrienes. Okay, it will increase the leukotrienes. All right, so this leukotrienes, it will causes the inflammation. Okay, it is causes the inflammation. Okay, sir, here we are giving a drug, what we call is in the non-steroidal anti-inflammatory drugs. Okay, NSAID, especially aspirin, Okay, so this aspirin or the NSAIDs are the COX inhibitors. Okay, it will blocks the function of the clock. So COX is blocking means there is no prostaglandin. No prostaglandin means no pain. Okay, so NSAID we are using to reduce the pain. Yes, we are using to reduce the pain, and there is no prostacyclin. Okay, so no prostacyclins means so there is less inflammation will be there. Okay, and the like COX is blocked means there is no thromboxane A2 means there is no platelet aggregation. Okay, so for the connection between the one platelet to another platelet, the thromboxane A2 is important. Here we are giving the NSAID. Okay, so that is the inhibiting the COX function, and the thromboxane A2 is not working. So no, thromboxane A2 is not working means the platelet are not clubbed together, or the platelet will not aggregate together, and platelet will unable to stop the bleeding. Okay, so that is the reason the aspirin will be used as in the antiplatelet also, and it will be used as in also as in the painkiller also, and it will be used in the treatment of the fever also. Why? Because it will be working as an antipyretic also. Okay, and painkiller also, and anti-aggregants also. Okay, so that is the very important thing, just you have to keep in your mind. Okay, so next comes to the point of the discussion in the question. So that is what it will, we need to monitor giving the aspirin. Okay, so that is the very important thing. We need to monitor for a sign of the bleeding, because the aspirin is the NSAID and which is blocking the COX. Okay, COX is blocked means the thromboxane A2 will be blocked. Okay, so thromboxane A2 is blocked means there is no any platelet aggregation. No platelet aggregation means highest risk of the bleeding. Okay, monitor the sign of the bleeding and bruising. It is the very important, and please do remember, don't give non-steroidal anti-inflammatory drug other NSAIDs like ibuprofen, okay, diclofenac with aspirin. Aspirin and other NSAIDs should not be given together. Okay, so very important point. And the second important point is again, don't give aspirin and warfarin together. Aspirin is the antiplatelet, increases the risk of the bleeding, and warfarin is the anticoagulant which reduces again the coagulation. Okay, so again both we are giving together means increase the risk of the bleeding. Okay, increased risk of bleeding will be there. So that is the reason we will not give the very important aspirin plus warfarin together. We should not ever give. Okay, so this was our golden points regarding the aspirin. Okay, sir, if the patient is experiencing the side effect of the aspirin. Okay, so what is the earliest side effect, sir? Remember beta, the tinnitus is the classical symptom. Okay, tinnitus in the, or the ringing sensation in the ear, we can say. Ringing sensation in ear. Okay, so which classical indicates the patient who is taking the aspirin is got aspirin toxicity. Okay, so that is the please do remember the sign of the, or the very important sign of the aspirin toxicity. The patient will experience the tinnitus or the ringing sensation inside the ear. Along with that, there is in the bruising of the skin will be there, means underneath the skin there will be bleeding will be there. Okay, so these are the very important points to be remembered here. Okay, so next comes to wherever the aspirin is contraindicated. So this concept of the race syndrome is repeatedly asked in the exam. So please do remember the race syndrome here. So wherever we should not give the aspirin is, so aspirin is contraindicated, or in the NSAIDs we can say they are contraindicated in the patient which is having the viral infections. Okay, why? Because the patient is having the viral infections or the viral fever. You are giving the aspirin means it will causes the hepatic encephalopathy. Hepatic means liver will get damaged, and encephalopathy, that is the brain will get damaged. Okay, so due to the viral infections, we are giving the NSAID aspirin in the viral infection, so that is causing the liver and brain to get damaged. So I call this one as in the race syndrome. Okay, so what we can say, call this one as in the, we call this one as in the race syndrome. Okay, so in the race syndrome, what are important organs are getting damaged? So liver is getting damaged, brain is getting damaged. So what is the scenario of the race syndrome? The patient is having the history of the viral fever, and you have given the aspirin in the viral fever, so which will cause the race syndrome. So whenever the child is having the viral infection, should not give the aspirin, as a very important point. So please do remember in your mind. Okay, and it will cause the active peptic ulcer disease. Yes, aspirin causes the active peptic ulcer disease. How, sir? How means, comes to the physiology here. Okay, aspirin is the NSAID and which is blocking the COX. Okay, which is blocking the COX means which is decreasing the prostaglandin. Okay, normally whenever the COX is stimulated, that time prostaglandin increases. Okay, so now COX is blocked means the prostaglandin will decreases. Okay, so now prostaglandin is decreasing means in the stomachs we have the hydrochloric acid, that is the HCl. Okay, so which is dangerous acid, and which acts on the stomach mucus, and it will damage the stomach mucus. So in order to protect the stomach mucus, the God have been created the jelly like substance, so that is the mucus. Okay, so this prostaglandin which stimulates or which increases mucus production, and this prostaglandin, it will protect the GI mucosa. Okay, so whenever we are giving the aspirin, so that time COX is inhibited, that time prostaglandin is decreased, that time mucus production is also decreased, and this HCl directly acts on the stomach muscular and the mucus layer. Okay, and it will start to cause the it will start to cause the peptic ulcer. Okay, that is the reason the NSAIDs will be having the second most cause of the peptic ulcer disease. Okay, so that is the NSAID. The first most common cause of the peptic ulcer disease is the bacterial infection. Yes, which bacteria causes the peptic ulcer disease? Yes, but mention your answer in the comment box. Which bacteria is responsible for causing the peptic ulcer disease? I'm waiting for your response, madam. Which particular bacteria which is having the most common incidence or which is having the most potential to cause the peptic ulcer disease? Yes, almost all people given the correct answer. That is the Helicobacter pylori. Okay, so Helicobacter pylori is the most common bacterial infection which causes the peptic ulcer disease, which including the gastric ulcer and the duodenal ulcer. Okay, so very important. And the second most common cause of the peptic ulcer disease is the NSAID induced peptic ulcer disease. Okay, there is a non-steroid anti-inflammatory drug induced peptic ulcer disease. Sir, why in the NSAID or why in case of the NSAIDs which causing the peptic ulcer disease? Means NSAID blocking the COX means which decreasing the prostaglandin. Prostaglandin is decreased means the mucus production will not be there. So the gastric layers which will directly expose to the HCl, okay, or the hydrochloric acid. So that hydrochloric acid is a dangerous acid which will break the mucus integrity and which will causes the very important conditions. So that is the our peptic ulcer disease. Okay, hope it is clear to every one of you. Yes, so yes. Next here, in case of the active already patient is having the active peptic ulcer disease, should not give the or don't give the our NSAID. Okay, next comes to the patient is having the hemophilia and the bleeding disorder. Okay, so patient is having the hemophilia and bleeding disorder. That time the aspirin is the anti-aggregate or the antiplatelet which will increase the risk of the bleeding. Again, the patient now is having the hemophilia, that is the coagulation factor deficiencies. Okay, so and the bleeding disorder the patient is having. Okay, already there is the bleeding disorder is there. Again, you are giving the aspirin means again it will increases the risk of the bleeding. So in the hemophilia and the bleeding disorder also aspirin is contraindicated. Okay, so next the aspirin, if the patient is having the aspirin allergy and if the patient is having the asthma, okay, so aspirin is contraindicated. Why in the asthma aspirin is contraindicated? Beta comes again to the physiology. Okay, so aspirin I told it will blocks the our COX pathway, but whenever the blockage is there this side, okay, so the stimulation will go maximum to the opposite side, so that is to the LOX. Okay, so whenever then the excessive LOX stimulation is there, excessive leukotrienes will be stimulated. Okay, I told the leukotrienes will be inflammatory mediators. Okay, so due to the COX blockage, the LOX will be stimulated much, and this LOX which will increase the leukotrienes, and that leukotrienes will cause the inflammation of the airway. So that is the reason the airways again get inflamed means, so the asthma will get trigger here. So in case of the asthma, should not give the very important NSAID. Okay, so hope the concept is clear to every one of you. Yes, so NSAIDs are contraindicated in the child with a viral infection, active peptic ulcer disease, hemophilia and bleeding disorder, and the asthma. Okay, so these are the very important points we have to keep in our mind. Okay, and if the patient taking the aspirin and now he posted for surgery, okay, so just 1 hour after we need to shift the patient to the OT. Okay, so now you come to know that the patient is taking the aspirin. So what as a nursing officer you will do? This is the practical challenge, the question to you are. Okay, the patient who is posted for the surgery, now we have followed all the pre-op orders. Okay, but whenever I will go to near the patient to ask something, that time I come to know that the patient is taking the aspirin medicine. Okay, and the last dose you have taken the today morning, right? So what you have to do? Option A, you have to inform to the surgeon, and option B, hide the tablet. Option C, Don't inform to anyone. Option D, inform to your in charge. So what you will do? Better the first thing we have to inform to the surgeon that the patient is taking the aspirin, and after 1 hour you people have been scheduled the patient for the surgery, because during the surgery in the intraoperative area, if the patient taken the aspirin and went, means there is highest chance of the huge bleeding and the hypovolemic shock and the death will be there, right? In order to avoid that one, we need to withhold the aspirin 72 to 72 hours before the surgery. Okay, so aspirin drug should be withhold before surgery at least 72 hours before surgery. Okay, at least 72 hours before the surgery, we need to withhold the aspirin or all the antiplatelets and all the anticoagulants, all the drugs which increases the risk of the bleeding. That one we need to withhold here. Okay, so hope the all the concept and scenario is very much clear to every one of you. I hope so. Okay, so here will be the next question. Which electrolyte increases the risk of the digoxin toxicity? Yes. Which electrolyte imbalance which increases the risk of the digoxin toxicity? I'm waiting for your answer in the comment box. I will cover all the important questions today. So only one more class will be remaining. I will cover that one in the next class. I told 2 classes enough to cover your Norcet syllabus for your on the pharmacology. Okay, so believe me, from this particular box only the question will be arising in your exams. Okay, yes. Which electrolyte imbalance increases the risk of the digoxin toxicity? Option E, the hyperkalemia. Option B, hypokalemia. Option C, hypercalcemia. And option D, hypomagnesemia. So what goes to the correct answer for this particular question? Yes. Well done, bro. Let me explain the concept to every one of you. Okay. So this chart you have to remember. Okay. If potassium level is decreasing, so that is hypokalemia. Okay. So it will causes increased risk of digoxin toxicity. If the patient have landed into the digoxin toxicity, okay, already patient is having the digoxin toxicity, that time the hyperkalemia will happens. That time hyperkalemia will happens. Sir, why? Sir, how? That everything I will explain in the in detail video of the digoxin toxicity after the exams. Okay, so just now we have the less time, so please do remember this chart. Okay, so it will be helpful for you all. Okay, if the patient is having the less potassium, he is having the highest risk of the digoxin toxicity. And if the patient already having the digoxin toxicity, for him there is highest chance of happening of the hyperkalemia. Okay, so please do remember this particular chart. It will be helpful and important for you. Okay, so in the question, which electrolyte imbalance increases the risk of digoxin toxicity? Okay, so if the patient is having the hypokalemia, that one it will increase the risk of the digoxin toxicity. And already patient is in the state of the digoxin toxicity, which is the electrolyte imbalance would have happened. So if the already patient in the digoxin toxicity, means the patient would have landed into the hyperkalemia. Okay, so hope it is concept is clear, and this particular question is clear. Okay, so the next question comes to you like this: which of the following is the classical sign of the digoxin toxicity? The classical sign of the digoxin toxicity among the given options: option A, bradycardia with visual disturbances and yellowish green color halos. Okay, then the option B is the hyperthermia, option C is the hypertension, and option D is the hyperkalemia. Yes, which of the following is the classical clinical sign of the digoxin toxicity? So that is the clinical classical signs, that is the bradycardia with visual disturbance goes to the correct answer, and the yellowish green color halos around the lights we will get when the patient is having the very important digoxin toxicity. Sir, what is the normal digoxin level, sir? when we can say that is the digoxin is entered into the state of the toxicity level? Yes, beta, the therapeutic serum level of the digoxin is the normal is the that is 0.5 to the 0.9 nanogram per ml. If it is going more than 2 nanogram per ml, which increases the risk of the digoxin toxicity, which increases the risk of the digoxin toxicity. Okay, so very importantly, this is the narrow index drugs we need to monitor regularly. How much is the digoxin is there in the blood? Okay, so please do remember. Then the increases the myocardial contractility, and that is what the digoxin we call this one as in the positive ionotropics. The question will arise in your exam. How the digoxin will works? Digoxin is works by increasing force of contraction, not rate of contraction. Okay, it will increases the force of contraction. So please do remember. Okay, so it will cause the heart to work with more force. Okay, so it increases the force of contraction. Okay, so that is the reason we will call this one as the positive ionotropes. Okay, ionotrope means it is having the effect on the contraction of the heart. Positive ionotropes means it is having the effect on the positive way of the contraction of the heart, that is the increasing the force of the contraction of the heart. Okay, so negative ionotropes means that is the decreasing the force of the contraction of the heart, means the negative ionotropes. Okay, so next comes to the it is in the negative chronotrope. Okay, so why I will call this one as the negative chromotropes means it will blocks the AV conductions and it will reduces the rate of the heart. Okay, so heart rate it will reduces, right? Heart rate is decreasing means we can call this one as in the negative chromotropes. Yes, the digoxin is the positive ionotropes and the digoxin is the negative chromotropes. So that is the reason it is slowing the AV node conduction, so it will cause the bradycardia. It will cause the bradycardia. So that is the reason whenever before giving the digoxin, we need to monitor for the 1 minute full. Okay, we need to monitor for the pulse. Okay, so if the pulse is less than 60 in the adult, don't give the digoxin. If the pulse is less than 100 in the children, don't give the digoxin, because the digoxin is already having the negative chronotropic effects. Patient is already having the bradycardia and you are giving the digoxin means again it will cause the bradycardia. So don't give the digoxin in a case of the bradycardia. So that is the very important thing. Just you have to keep in your mind. Okay, so the next a golden point of the discussion on the digoxin is, so nursing consideration I just told, we need to check the pulse for the full 1 minute. So which pulse we need to check, sir? Whether the carotid, apical, okay, or the radial, brachial, where you have to check? Yes, we have to check the apical pulse for the full 1 minute. Very important question. That means we need to monitor before administration of the drug, because if the heart rate of the adult is less than 60 beats per minute, we will withhold the digoxin. Heart rate in the children, if it is less than 100 beats per minute, we will withhold the digoxin, because the digoxin increases the again risk of the bradycardia. Hope it is clear to everyone of you. The first golden point, the best site to assess the pulse before giving the digoxin is the apical pulse. Okay, so the duration of the pulse assessment in the before giving the digoxin administration is the 1 full minute. Okay, so what is the margin of the pulse rate where we have to withhold the digoxin? In the adults it is less than 60, withhold. In the children it is less than 100, withhold. Okay, so then the monitor the electrolytes very importantly. So that is the especially for the hypokalemia. Okay, why? Because the potassium is decreasing means risk of digoxin toxicity increasing. Okay, so risk of the digoxin toxicity increases if the potassium is decreasing. Sir, whether can we give the furosemide and digoxin together, sir? Yes. Can we give the digoxin and furosemide together? But I told what all are the drugs which reducing the potassium should not give with the digoxin, because whenever the potassium decreases, that time digoxin toxicity will be increases. So don't give the diuretics, which is reducing the potassium along with the digoxin. Okay, so furosemide should not be given along with the patient who is taking the digoxin, because furosemide causes the hypokalemia, and hypokalemia causes the risk of the digoxin toxicity. Okay, so that is the very important thing we need to educate the patient, right? So along with we need to monitor for the liver function test and serum digoxin level we need to monitor, and we need to educate the patient to report symptom of the toxicity immediately. Okay, so that is the earliest sign of the digoxin toxicity is that is a GI system related. The patient is having the nausea, vomiting, and abdominal pain. Okay, so this is the earliest sign of the digoxin toxicity. So we need to educate to the patient if the any sign of the digoxin toxicity happening. So that one, ask the patient to immediately report. Okay, because we need to take care of the patient very carefully here. Okay, so again, if the patient is having the nausea, vomiting, means potassium is again getting lost. Again, there is a more severity of the digoxin toxicity will be there. Okay, so that is the reason whenever the patient will experience the nausea, vomiting, so we will ask the patient to inform us immediately. Okay, which will be a sign of the digoxin toxicity, or which may increase the risk of the sign of the digoxin toxicity. Okay, so that is the very important thing you have to keep in your mind. Okay, so next, along with that, be cautious with the concurrent potassium wasting diuretics. Okay, that is only I told. The furosemide we should not give with the patient who is taking the digoxin, because the furosemide causes the hypokalemia. Hypokalemia increases the risk of the digoxin toxicity. Okay, so it's the very important thing, just you have to remember. Okay, next, the antidote of the digoxin. So this will be an important one. Antidote of the digoxin. So digoxin, it is a specific antibody fragments we can say, or we can say the digoxin. So digoxin is the antidote we are using in the treatment of the digoxin toxicity. Okay, so hope all the concept is very much clear on the digoxin. Let me quickly revise all the concept on the digoxin better. So which electrolyte imbalance which increases the risk of the digoxin toxicity? Yes, if the potassium is low, which increases the risk of the digoxin toxicity. So that is the reason don't give diuretics with the digoxin. And if the patient is experiencing the nausea, vomiting, we will ask her to inform immediately, because hypokalemia, it will again increases the risk of the digoxin toxicity. Okay, so very important first golden point. And the second golden point, that is the classical digoxin toxicity sign will be or that is the bradycardia with visual disturbance and the yellow green color vision. And if the exam is asking early sign of the digoxin toxicity, that is the that is related to the GI system. Okay, that is our nausea, vomiting, and abdominal pain. Okay, so these are the very important early sign of the our digoxin toxicity. So please do remember the very important question. Okay, so this is the very important one. And visual disturbances, yellowish green color halos, and the bradycardia. So this will also be a digoxin toxicity. Why and how I have explained everything in detail in perfect. Okay, so next, serum lithium level. This is the from the standard book. Okay, so this is the normal level, 0.5 to 0.9 nanogram per ml. If it is going more than 2 nanogram per ml, then only we will call this one as the toxic level of the digoxin. Okay, so before giving the digoxin, we need to check for the full 1 minute of the pulse. The site of the pulse assessment is the apical pulse. And how the digoxin will work? Digoxin will work by increasing the force of contraction. Okay, so it will not increase as the rate of the heart. It will not increase as the function of the heart. Okay, it will increase the force of the contraction, where the heart will contract more forcefully, and so the blood which is accumulated or which is congested in the heart, it will goes out of the our body. Okay, so that is the digoxin is the drug of choice in the chronic heart failure. Okay, so in the acute heart failure, the drug of choice is, yes, let me give the one more golden point so that will be helpful. Drug of choice in heart failure, so please do remember and write. Drug of choice in heart failure. So in the heart failure patient, the drug of choice are like this. In case of the acute condition, okay, so that we will give here dopamine and dobutamine. Best one is the dopamine. Okay, so this one is the first best answer. Okay, in case of the chronic heart failure, okay, in case of the chronic heart failure, the drug of choice is digoxin. So please do note this particular point. Okay, so this will be a very important for you all, right? So hope it is clear to everything, clear on the deduction to everyone. Okay, so yes, the rapid revision and golden bond chanting also we have done on this one. Okay, so next is, this all points I have explained in perfect in detail. Right, the next question is here in front of you all. So please do read the question properly, then try to give the best answer in the comment box. Which laboratory test is routinely used to monitor the anticoagulant effect of the warfarin? Yes. Which laboratory test we are routinely using to monitor the anticoagulant effect of the warfarin? Option A, activated partial thromboplastin time. Option B, prothrombin time, or the INR, that is the international normalization ratio. Then option C, bleeding time. Option D, platelet count. So which one we are using routinely to monitor the anticoagulant effects, especially the warfarin effect? Better. So in the anticoagulants, we are using the two anticoagulants routinely. So that one is anticoagulants. Two we are using routinely. One is the heparin, another one is the warfarin. Okay, one is heparin, that is especially the low molecular weight heparin. So how we will give the heparin? So this is whenever the patient requires the heparin on the subcutaneous route, we will use the low molecular weight heparin. Okay, so for the IV route, we will use the unfractionized heparin. Okay, unfractionized heparin, right? If the patient requires the anticoagulant for the long term, so we will give the oral heparin. So that is the what we call is the or not heparin. So that is the warfarin. Okay, so if the patient is requires the anticoagulant for the long term, so that one we will use the oral route of the anticoagulants. So that is the warfarin. Or another name of the warfarin is the coumadin. Please do remember, coumadin and warfarin both are same. So don't get confused in the exams. Okay, so coumadin and warfarin both are same, and so we are using this one for the long term management, especially to the oral route. Okay, so whenever we are administering this warfarin or the coumadin, so we need to assess the patient for the prothrombin time and international normalization ratio. We need to regularly assess because it is having the risk of the bleeding. Okay, so that is the very important thing. Again, if the patient is having the heparin or the low molecular weight heparin subcutaneously, or the IV route of the heparin, so that is the unfractionized heparin IV route we are giving means, so that one a very important one. We need to monitor for the activated partial prothrombin time. Okay, so APTT will be monitored in a case of the heparin, and PT and INR will be monitored in case of the warfarin. Okay, so these are the very important things. So you people have to remember here. Okay, so here is the next question. Yes, which of the following is the specific antidote used to reverse the effect of the heparin? We are giving the heparin here. This is the every Norcet fixed question. Okay, this one is the very important fixed question in every Norcet. That is the antidote of the heparin, antidote of the warfarin, okay, antidote of the opioid, okay, and antidote of the ethanol. So these are the some very important questions which have been repeatedly asked in the exam. Okay, which of the following is the specific antidote we are using to reverse the effect of the heparin? So for the reversing the effect of the heparin, we are using the drug called as the protamine sulfate. Okay, so protamine sulfate is the specific antidote which we are using to reverse the effect of the heparin, or we are using as the antidote in the heparin, that is the protamine sulfate. This is the very important thing, just you have to keep in your mind. Okay, so next comes to the the important golden point chanting on the antidotes. Okay, so this is your very important chart. Okay, from here there is highest chance of asking at least 2 questions in your exam. Okay, at least 2 to 3 questions in your exam. The first one is the universal one, the repeated question, that is the heparin. Okay, the anticoagulant, and the protamine sulfate is the antidote for the heparin. Okay, so please do remember. Then comes to the warfarin. Okay, for the warfarin also anticoagulant, bleeding risk is more. Reduce that one. The vitamin K we are giving. Okay, so as the antidote. Then the paracetamol. Okay, so paracetamol, N-acetylcysteine is the antidote for the paracetamol. It is the important one. In every Norcet, there was one fixed question from the paracetamol. Okay, so last previous three Norcet continuously a question from the paracetamol, right? So paracetamol is mostly damaged to which organ? Paracetamol will mainly and mostly device to the which organ? So what to mention in comment box? Comment box. Yes, paracetamol is mostly and mainly damages to the which of the organ? Option A brain, option B lungs, option C liver, option D gallbladder. Yes, कौन सा लॉक कर दो? Which one I have to lock? Option C liver or option A brain? Yes, beta. So option C, liver is the main organ which will get damages due to the paracetamol poisoning. Okay, so never ever try to take the paracetamol. Okay, so yes, not it means not to take much more than the 4 gram. Okay, per day, right? So previously the maximum dose allowed was 3 gram. Now it was the 4 gram, right? So please do remember the paracetamol maximum how much we can use per day. So we can use the 4 gram of the paracetamol per day, right? So paracetamol or the acetaminophen you are taking more than 4 gram in a day, so there is chance of the damage to the liver will be there. Okay, so that time we have to give the N-acetylcysteine, okay, as an antidote, right? So next comes to the opioid poisoning. Okay, so morphine or the heroin poisoning, what we can say. Okay, so here we are using the naloxone. Okay, so don't confuse between the opioid poisoning and OP poisoning. That is the organophosphorus poisoning. Both are the different thing, beta. Okay, so yesterday one student have sent that the sir in the old classes for the OP poisoning you told the antidote as the atropine, sir. Actually for OP poisoning we are giving the naloxone, but that is the opioid which is very much different. So that is the what you people should and must have some basic knowledge. Okay, yes, it is not bad thing, but still it is you people should and must have some basic knowledge, right? So that is my kind like from my side request to every one of you, right? So next is the opiates. Opiates we are giving the antidote as the naloxone. Then the benzodiazepines. Okay, for the benzodiazepines the antidote is the flumazenil is the antidote for the benzodiazepines. So this is the both are very important. So any one question can arise in your exam. Okay, from the opiates or the from benzodiazepines. Okay, so the next one is the organophosphate or the OP poisoning or the insecticides chemical when the like farmer, okay, who will go is who is enters his field with some insecticide chemical to kill the some insects in his own field. Okay, so whenever the farmer will exposed to that particular insecticide chemical, so there is highest chance of the getting land into the OP poisoning or the organophosphorus poisoning, because in the insecticides they have used of the one chemical called as the malathion. Okay, so that malathion is in the very dangerous what we can say cholinergic chemical. Okay, so which will increase the all the cholinergic activity of the body, means overproduction of the saliva from the mouth. Okay, and the pupils will be completely like constricted and pinpoint pupil will be there. Okay, and along with that the patient will land into the bradycardia. So all the parasympathetic nervous system or the cholinergic symptoms will arise in the organophosphorus poisoning. Okay, so first drug we have to choose here as the atropine. Okay, in the question they have mentioned, the farmer went to the field with insecticides and he have exposed the insecticides there. Sorry, he exposed to the that particular organophosphorus poisoning, and now he brought to the hospital and the patient is having the bradycardia, hypersalivation, pinpoint pupil. Okay, and we have given the atropine. Maximum we have given the atropine. Still the patient is not recovering. What is the next best drug? So what is the next best drug? That is the prolidoxim or the topam is the next best drug which we are using in the treatment of the our very important organophosphorus poisoning. Okay, so next in case of the iron overload we will give the diferoxamine. Okay, important one, iron overload, which antidote will be given? Diferoxamine. Then the methanol, the last Norcet question beta. So that is the pomipizole we can use or the ethanol we can use, the very important one. Okay, for the methanol toxicity the first answer goes to the pomipizole. Okay, if it is not there in the option we can go for the ethanol. Okay, so very important, the antidote for the methanol is the pomipizole or the ethanol. Okay, so next comes to the beta blockers. For the antidote of the beta blockers we are given the glucagon. Okay, so next digoxin. For the digoxin, that is the digoxin specific antibody or the diazepam is the very important Like antidote, we are giving the digoxin toxicity. Already we have discussed. Okay, isoniazid, anti-tubercular drug. For this one, there is highest chance of the peripheral neuropathy. So in order to avoid that one, we are giving the antidote, that is the pyridoxine. Okay, that is the vitamin B6 will be given in the case of the isoniazid toxicity. Okay, next comes to the cyanide poisoning. So in the cyanide poisoning, we are using the lilicate. Okay, so what is the lilicate? It is the combination of the three things. So that is the sodium thiosulfate and amyl nitrate and the sodium nitrate. Sodium thiosulfate, amyl nitrate, sodium nitrate. So all three together it will call as the lilicate. Lilicate will be used in the case of the sodium cyanide poisoning. Sorry, not sodium. It is used in the case of the cyanide poisoning. Sir, among these all lilicate, if you want to choose the one answer means please do choose the sodium thiosulfate as the best answer. Okay. So hope it is clear to everyone of you. Next, in case of the carbon monoxide poisoning. Okay. So that it will be 100% of the oxygen and hyperbaric oxygen therapy means oxygen with high pressure and 100% of the oxygen we will give it to the patient who is undergoing the carbon monoxide poisoning. Okay, so hope it is clear to every one of you. Yes, is that clear better? The antidotes are clear. The concept from the heparin, warfarin is clear. Okay, so and along with that the digoxin is clear, aspirin is clear, right? And the diuretics are clear. Many things clear today in this particular class, right? So hope you people enjoyed this particular session very well. Okay, so in the yes, we will continue session for the next 20 more minutes. Okay, so just the syllabus is huge here, so I don't want to lag off the any syllabus here. Okay, so here is the next question in front of you all. So please do read the particular question and try to give the best answer for this one. Okay, so in the last question we have discussed the antidotes. Okay, that was the very important question, and here again the question is here in front of you all. So filgrastim is primarily administered by which route? Yes, fatapat do mention your answer in the comment box. Okay. Yes. Well done, beta. Yes, almost all people given the correct answer. The filgrastim is primarily administered by the which route? So that is it is primarily administered by the subcutaneous route. Okay. So along with that, do remember the heparin also will be administered by the subcutaneous route. That is the low molecular weight heparin, and the insulin will also be administered by the subcutaneous route, and the filgrastim. Filgrastim also will administer by the subcutaneous route. So please do remember all three points. Okay, because it is important. Sir, what is the meaning of the filgrastim and which drug is this, sir? Here we will use this one, sir. Better, we will use this one in a treatment of the leukocytopenia. Okay, so first I will tell how to remember. This is the fil, this is the grass stem. Okay, fil means restore, grass means granulocytes. Okay, stim means for stimulating the bone marrow. Okay, so bone marrow stimulation will be there. Okay, so and these drugs we are using to restore the granulocytes means whenever the patient will take the drugs called as the clozapine, carbamazepine, and the chemotherapy, here the WBC will get decreases. Okay, white blood cells will get decreases. So whenever there is a decreased white blood cell, we will call this one as in the leuco, that is the white. Okay, cyto, that is the cell, and penia, that is the decreased white blood cells. Okay, in this particular situation, in order to increase the white blood cells, we are giving the drug called as the filgrastim. Okay, so this filgrastim will be given after every chemotherapy. Okay, and the patient who is taking the carbamazepine, highest chance of the decreased WBC. Okay, so we need to monitor the patient for the leukocytopenia, and the patient who is taking the clozapine. Okay, so he is also highest risk of the low WBC and leukocytopenia will happen. So that is the reason whenever the patient takes the clozapine, carbamazepine, chemotherapy, always assess the patient for the leukocytopenia and keep the patient separate. Okay, keep the patient separate. Keep the patient separate. Okay, why? Because the patient which is landing into the low WBC means there is increased risk of infection. Okay, wherever the patient WBC will get decreases, there increases the risk of the infection. So that is the reason whenever you are caring the patient who is taking the clozapine, carbamazepine, okay, chemotherapy, please use the aseptic techniques. Okay, so please use the like infection prevention, all the methods, because the patient WBC is already low, and if you are going with the contaminated hand, the patient will easily get infection. Okay, so he came to the hospital with another reason, and again he is getting the lots of the super infections. Okay, so that is not going to be a good, that is not going to be a good thing. Okay, so please do remember. Okay, so in this particular 3C you have to remember, because these 3C are maximum asked in the exams. Okay, so that is the reason, in order to replace the granulocytes, okay, the WBC, we will give the injection filgrastim, so that will be given by the subcutaneous route. Okay, and here the heparin also will give the subcutaneous route, insulin also will give the subcutaneous route, and the filgrastim also we will use in the subcutaneous route. Hope it is helpful for every one of you. Okay, so along with the these particular 3C what we have discussed here, the clozapine, carbamazepine, and chemotherapy. So 3 more C's are there here. Just it is unrelated, but you can remember this one like this. Okay, so 3C stands here as in the cough, coryza, and conjunctivitis. So these 3C signs will be seen in which of the particular condition. Okay, so which is the communicable disease we will study in the community health nursing. Okay, so in which communicable disease we will see cough, coryza, and conjunctivitis. Yes, what the 3C stands here: cough, coryza, and conjunctivitis. So that is cough is the, yes, you know, cough is there, means the cough. Coryza is means, yes, coryza means that is the continuous running of the water from the eyes and nose. So that is the coryza, and conjunctivitis means inflammation, infection of the our conjunctiva. Okay, so this cough, coryza, conjunctivitis will be again seen in a case of the measles. Okay, so this will be seen in case of the measles. Okay, so along with this 3C, you remember one more 3C. Okay, so 3C signs, classical pneumonic we use. Okay, so in which situation? Okay, especially mother feeding a baby. Okay, mother is feeding a baby, that time the patient is having the coughing, cyanosis, and choking, the 3C sign. Yes, 3C sign, which is classical pneumonic, when the mother is feeding the baby. So in which situation we will experience the 3C sign? So that is the coughing, cyanosis, and choking. Yes, so that will be in case of the tracheoesophageal fistula. Okay, so in case of the tracheoesophageal fistula, whenever the mother will feed to the baby, that time the milk will not go inside the stomach, because there is in the fistula, like esophageal atresia will be there. Okay, so tracheoesophageal fistula with esophageal atresia. Okay, with the esophageal atresia. Okay, so the milk which is fed by the mother, it is not going into the stomach, which is filling in, which is accumulating in the esophagus, and which is shifting from the esophagus into the lungs. Okay, that time the choking will be there, the cyanosis will be there, and the coughing will be there. Okay, that is especially when the mother feeds the baby. Okay, so this is the 3C sign, very very importantly. So please do remember this one. Okay, so hope it is clear to every one of you. Right, so the next question is here. Yes, which of the following is the drug of choice for the treatment of the myasthenia gravis? A very very important one. In a treatment of the myasthenia gravis, which of the following is the drug of choice? Option A, prednisone. Option B, neostigmine. Option C, donepezil. And option D, omalizumab. Beta, recently whenever we have discussed the asthma, so that time I told there is one monoclonal antibody we will use in the treatment of the asthma. So that is the omalizumab. Okay, so that is the omalizumab is the drug we are using as a monoclonal antibody in the treatment of the asthma mainly. Okay, so we will not use that one as a primary drug or the drug of choice for the myasthenia gravis. So I am eliminating the option D. Next come to the donepezil. Okay, so this donepezil, it will be given in the case of the Alzheimer's disease. Okay, so to increase acetylcholine in brain. Okay, in the brain, right? So that is the donepezil we are giving. Okay, so prednisone is on the steroids, so steroids will not go via drug of choice. Okay, so steroids I am eliminating here. Then comes the drug of choice for the treatment of the myasthenia gravis. The remaining one option, that is the neostigmine. Okay, so in the option you will get the neostigmine and pyridostigmine. Again the first answer goes to the neostigmine, and the second best answer goes to the pyridostigmine. Okay, So please do remember, right? So hope it is clear to every one of you. Yes, what happens in the myasthenia gravis? Understand the concept. In the myasthenia gravis, okay, so there is deficiency of the acetylcholine at neuromuscular junction. Okay, so this is what we call as the myasthenia gravis, which makes the muscles to get weak. Okay, so the most common and the early sign of the myasthenia gravis is the ptosis. That is the drooping of the eyelid because of the weakening of the muscles. Okay, so here the acetylcholine is decreasing at the neuromuscular junction. So the treatment purpose should be increase acetylcholine at the neuromuscular junction. So I will give the two drugs, very important drugs. Is one is the neostigmine and another one is the pyridostigmine. Very important. And physiostigmine not useful here. Okay, physiostigmine not useful here. Okay, so physiostigmine also will increase the acetylcholine, but it increases it in brain. Okay, so physiostigmine, it will increase in the brain. Okay, so whenever there is in the acetylcholine deficiency in the neuromuscular junction, that is the myasthenia gravis. Whenever there is in the acetylcholine deficiency which is happening in the brain, means that is the Alzheimer's disease. Okay, so in the Alzheimer's disease also, which neurochemical will decreases? Acetylcholine. In the myasthenia gravis also, which neurotransmitter decreases? Acetylcholine. But in the myasthenia gravis, it is decreasing at the neuromuscular junction, and in the Alzheimer's disease, which is decreasing in the brain. So physiostigmine useful in the treatment of the Alzheimer's disease in order to increase the acetylcholine in the brain. Okay, and the donepezil also we will use in the treatment of the our Alzheimer's disease, not in the case of the myasthenia gravis. Okay, so hope it is clear to every one of you. So here is the next question, which is awaiting for your brilliant answer. Okay, in the comment box. So please don't mention your correct answer in the comment box. Yes. Which of the following is the common side effect of the NSAID? So already discussed the question. I will not going to waste your much time here. I told the NSAID, especially the drugs, what we can say, ibuprofen, okay, diclofenac, then the indomethacin, then the aspirin. So many drugs are there in the NSAID classification. So these all are the painkillers. These are the painkillers which reduces the pain. How it will reduces the pain? It will reduces the pain by decreasing the prostaglandin. Okay, by decreasing the prostaglandin. And I told the prostaglandin is much necessary for the mucus production. Okay, mucus production, especially in the stomach. Right? So prostaglandin is decreased means mucus production also decreased. So mucus production decreased means increased risk of the gastric ulcer. Better. The NSAIDs will cause the bronchoconstriction, not the bronchodilation, because I told it will block the COX and it will stimulate the LOX. So LOX means there is a stimulation of the leukotrienes. Leukotrienes stimulated means inflammation of the airway. So bronchodilation. Okay, sorry, bronchoconstriction, not the bronchodilation. I am eliminating the option A. Then NSAIDs common side effect is clot formation. Better, NSAIDs also it is inhibiting the thromboxane A2, so it will inhibits the clot formation. Okay, so it will not makes the clot formation, it will inhibits the clot formation. So I am eliminating the option C also. Then comes to the option D. Okay, it is not unrelated to the NSAID, so I am eliminating that one. And the answer for this particular question goes to the option B. So the gastric ulcer will be the most common side effect of the NSAID, and this is the second most common cause for the peptic ulcer disease is the NSAID. Okay, so it is clear to every one of you. Yes, already discussed the question, so I superficially have brushed it off again. Okay, so the next one. Yes, what is the primary role of the phenobarbital in the treatment of the neonatal jaundice? In the treatment of the neonatal jaundice, we are using the drug called as the phenobarbital. Okay, what is the primary role of this particular drug, phenobarbital? The drug of choice for the neonatal jaundice, that is the phenobarbital. Yes. What is the primary role of the phenobarbital in the treatment of the neonatal jaundice? Option A, inhibits the bilirubin production. Option B, increases the bilirubin excretion. Option C, promotes the bilirubin conjugation. Option D, reduces the red blood cell destruction. So what goes to the correct answer? What is the primary role of the phenobarbital in the treatment of the neonatal jaundice? Option A, inhibiting the bilirubin production. So it is not having any role in the production of the bilirubin. I am eliminating the option A. So then option B comes to increase the bilirubin excretion. It is not having the role in the excretion of the bilirubin. Excretion of the bilirubin will be happens due to the like GI system and urinary system. In the urinary system, through the urine, it will eliminate the bilirubin will eliminate as a urobilinogen. Okay, so in the stool, the bilirubin will eliminate as in the stercobilinogen. Okay, I will explain that one. Don't worry, right? So elimination will be done by the renal system and the GI system, not by the phenobarbital. Right? The option C comes to the promotes the bilirubin conjugation. Yes. So this is having the role in the conjugation of the bilirubin. Okay. Next comes to the reduces the red blood cell destruction. So red blood cell destruction we need to reduce means we need the enzyme one that is the G6PD enzyme. Okay. So G6PD enzyme is there means yes, this G6PD enzyme will protect the red blood cell and reduces the destruction of the red blood cells. And phenobarbital is not having any role in the reducing the destruction of the red blood cell. I am eliminating the option D also. Okay. So next comes to the point of the discussion, how it will promote the bilirubin conjugation. So please do remember, we have the bilirubin which is unconjugated or the indirect bilirubin will say. So unconjugated, or we can say indirect, or we can say water insoluble, or we can say fat soluble. Okay, so unconjugated bilirubin we can also say the indirect bilirubin, water insoluble bilirubin, or the fat soluble bilirubin. Okay, so this particular bilirubin, it will not get excreted out of the body easily. Okay, it will start to accumulate in the body, and this unconjugated bilirubin is the fat soluble which will easily crosses the blood brain barrier. And in the jaundice, we are not treating it immediately, means this unconjugated bilirubin, it will crosses the blood brain barrier and it will causes the damage to the brain. Okay, due to the jaundice, the brain is get damaged, means that is what you call as the kernicterus. What is the kernicterus? Kernicterus is the damage to the brain due to the excess accumulation of the unconjugated bilirubin in the brain. Okay, so that is the hepatic like due to the excess accumulation of the unconjugated bilirubin, brain is getting damaged, means that is what we call the unconjugated bilirubin. Sir, this is the unconjugated bilirubin. So how we have to excrete this one out, sir? Means this unconjugated bilirubin we have to convert into the conjugated bilirubin. Sir, how to convert this one conjugated bilirubin? So what is the conjugated bilirubin? So this is the direct bilirubin we can say. Okay, or we can say this one is in the water soluble, or we can say fat insoluble. Opposite of the our unconjugated bilirubin, that is our conjugated bilirubin. And this conjugated bilirubin, it will easily excrete out of the body. Okay, so for the converting of the unconjugated to the conjugated bilirubin, we need one enzyme, that is the UDPGT. Okay, so UDPGT enzyme is very much necessary. Okay, so this enzyme, our drugs, that is the phenobarbital. So these drugs will stimulate the production of the UDPGT. Okay, this UDPGT, it will convert the unconjugated bilirubin to the conjugated bilirubin. Okay, this conjugated bilirubin, okay, it will eliminate through this stool. Okay, as a stercobilinogen, it will eliminate in the stool. Okay, so in the urine, it will eliminate the urobilinogen. Okay, it will eliminate as in the urobilinogen. Okay, so these are the very important thing you have to consider in your mind. Okay, so in the stool, which format? In the stool, which format the bilirubin is eliminating? That is in the format of the stercobilinogen. In the urine, in which format the bilirubin is eliminating? That is in the form of the urobilinogen. Okay, so what is the conjugation bilirubin? So that is the conversion of the fat soluble and water insoluble bilirubin to the water soluble and fat insoluble bilirubin. So that is what we call as in the conjugation of the bilirubin. Okay, so that is done by the UDPGT enzyme, and our phenobarbital is the drug. Okay, so which is having the main role in the conjugation of the bilirubin. Okay, so it is the correct answer, promotes the conjugation of the bilirubin, goes to the correct answer for this particular question here. Okay, so hope the today's session you people have been enjoyed a lot. Okay, so in the tomorrow session we will again discuss the most important question. Okay, so I told in the two classes all the possible and all the important questions will be covered. In the tomorrow session especially we will discuss on the uh, atropine, adrenaline dose in the neonatal resuscitation, how to calculate that one, and the atropine, what is the dose in the revised criteria in the bradycardia, and every all the important aspect of the adrenaline, atropine, and rest all the important drugs, some side effect of the antibiotics. Okay, so that one we will discuss in perfect in detail because it is important for your exams. Okay, so hope today's session is much enjoyable for every one of you, and any one of you are waiting for the test series. Okay, so tomorrow onwards in the master nursing classes app the free test is going to be happen. Okay, so please do download the master nursing classes app, the link I have given in the description box. Okay, so thank you for watching the class till the end, and if you are still not part of our WhatsApp group and WhatsApp channel, Telegram channel, so I have given the link in the description box. You can join from there, and for the Norcet free test you can join or download our master nursing classes application. Okay, so if anyone of you are new to the channel, so please do subscribe to the channel, so it will help me to get motivated and work on more. Okay, and to get the best content towards you people. So thank you so much for the watching the video till then. We will meet again in the tomorrow's class same time 6 p.m. tab tak ke liye jai hind, jai bharat, take care, love you all, bye bye.